Hello there, guys. Um, Today we're going to be doing some neurological emergencies, kind of a review over the chapter, just to kind of help out, get a little bit better of an understanding here. So, right now, sorry. Um, Move on to the next chapter. Um, or sorry, the next slide. The basic introductions here is strokes are the fifth leading cause of death in the United States. More commonly than not, the people you're going to be seeing having strokes are geriatric patients. Mexicans, African Americans, and Asians are actually statistically more likely to have strokes than most other races, and then obviously the genetically predisposed tend to run the highest risk. Seizures and altered mental statuses can mean many different things and can also mean many different treatments. If you've got someone who's suffering from, hypoxia versus hypoglycemia, they both have altered mental statuses and they both can present with seizures. So it's very important to recognize what the issue is so that you can do the best treatment that you can. So next we're going to move on to the brain's anatomy. So right here we have the cerebrum. Cerebrum is your biggest part of your brain, and it also has two hemispheres. It has three different lobes, as you can see right there. It's got the frontal, parietal, and occipital, and obviously the temporal on the side. So the front of your cerebrum is in control of emotions and thoughts. The middle will be your sensations and movements, and the back will be your process and sight. So just with medical terminology, you'll have anterior and posterior. So if you do hear anterior, will be referring to your front. So the anterior would obviously be your emotions and thoughts. Midline would be your sensations and movement, and your posterior would be your process and sight. The easiest way to remember that is like you split someone into like with a line right down the middle. You know, uh, it's kind of how the lines work. I'll do that more once I get onto anatomy. Um, so then next we'll have the cerebellum. The cerebellum controls muscles and body coordination. It's responsible for complex tasks with many muscles. So things like playing the piano, guitar, those kinds of movements will generally be controlled by your cerebellum. Your brain stem regulates breathing, blood pressure, swallowing, pupil constriction. So generally your brain stem is in charge of a lot of the autonomic portions of your life. Um, so big things you should just be picking up on are your foramen magnum. That will be the opening at the base of your skull. That's where you see things like your brain stem coming out. And that's also when there's a herniation due to intracranial pressure where that'll be coming out of. So there's that too. Um, so the next thing is the messages are sent to and from the brain through an interconnected system of about 12 cranial nerves, which run from your various parts of your head, such as your eyes, ears, nose, and face. Remaining, the remaining parts of your nerves will jet out of your skull down your spinal column. So, next up, we'll be moving on to pathology. Sorry. So brain dysfunction and neurological symptoms generally result in things like lack of consciousness, speech, and voluntary muscle control. And you have to look at it as, well, if there's a lack of some sort of important substance, and as you'll see here, the brain is sensitive to oxygen, glucose, and temperature. So obviously these things are all impacted by the fact that the big thing about circulation is moving your hemoglobin, which is rich with O2, once it's left your heart, and moving so that diffusion can occur and your body can maintain homeostasis. So when you're having poor like heart and lung function, I say cardiopulmonary because that's the bringing of the both into one. Can result in coma and brain damage, and this is because the lungs and your heart control the biggest part of your body, which is the circulatory system. Because without circulation, obviously diffusion can't occur, and nor can oxygenation occur. which basically just prevents any sort of cell function, thus resulting in death. Um, so the big things to look for when you're looking at symptoms will be things like hypoxia. So this is a pretty good rule. If you're seeing things like low oxygen, which is hypoxia, anxiety, restlessness, and confusion can occur. That's why you'll hear like pilots will talk about it, and you'll hear about like a pilot crashed his plane because he was just completely confused inside the advanced cockpit, not being able to continue his flying. Hypoglycemia is one of the few things here that when we come to the stroke section, you actually have to think of in the situation because they can mimic strokes. Obviously, more milder cases, it can just be mild confusion, but in more advanced cases, you can see things like mimicry of stroke, which can really be an important part of diagnosing a stroke and determining what you're going to do, because someone with hypoglycemia might not necessarily need to go to a stroke center. So, there's that. So headaches are a very common chief complaint, very similar to like abdominal pain and chest pain. A lot of people have them, and a lot of people will call 911 reporting of them. So you have to determine what they are and what's going on with them. So migraines are caused by changes of blood vessel size in the base of the brain. The pain is generally throbbing, pounding, or pulsating. Uh, it's often associated with nausea and vomiting, and maybe like I guess similar to like the seizures aurora, you can see them before they happen, like a visual warning or flashing lights or partial vision loss will occur before these massive migraines. These can last upwards of several days, or sorry, days to just a few hours. So you got to kind of diagnose this. And migraines in acute cases, generally when they're younger, will be just a migraine, but can also be a symptom or due to the description of pain, it can be similar to someone describing a stroke. So you have to pay attention and look at what's going on. The signs and symptoms are your biggest case, and medical history will always help you out in determining. Because a lot of people are probably just going to have a migraine when they call for that kind of head pain, but it could also be a stroke for all we know. Next, we'll move on to is tension headaches. So a tension headache is due to constriction of muscles in the head and neck, resulting generally from stress. So when you've been studying too much and you get that squeezing, dull, achy headache, that's generally your tension headaches. These are not associated with other symptoms. That's a big thing you have to look out for too. Sinus is pressure resulting of fluid accumulation of fluid in the sinus cavities. So you got to remember, everything has its place, and when there's not homeostasis, you're not able to breathe the best or just move oxygen for your body. It can lead to, pressure and issues that can lead to that. The nice part about sinus is it's generally self-regulating, and it won't really go too far. But the big things you kind of have to worry about here are like the sinus infections, but normally these are not a hospital call, if at all. They are normally presenting with cold-like symptoms or nasal congestion, cough, and fever. Pain will be increased when they bend over or you move their head forward. Most headaches, as I said, are not life-threatening. The chief complaint of a headache does not require medical attention. But hemorrhagic stroke, brain tumors, and meningitis all are serious neurological conditions that include headache as a symptom. Consider things like rapid onset and severe headaches and onset with fever, stiffness, or seizures or altered mental status as a very big concern, because they can all be very big indicators of a seizure. And as I go on to the seizure section, or not seizure, sorry, as I go on to the stroke section, I will explain more about like red flags and how that all works exactly. When you're discussing someone who has a headache, it's always important to ask if they've had recent head trauma, because within hours or days, you can actually see people having hemorrhagic stroke due to head trauma. So whenever you have them, specifically headaches, you do want to have a complete medical assessment And if it's life-threatening, it's always going to want to be transported to the hospital. You know. Also, if there's multiple patients on scene complaining of headache poisoning, consider CO or carbon monoxide poisoning, because carbon monoxide does represent, or when your body does it, you can't really determine it. It's a lot more if like someone has a leaky, what do you call them, water heater. They'll generally have signs of carbon monoxide poisoning, because carbon monoxide does mimic O2. So when you're using your SpO2 reader, it can actually leave you to the inclination that they do not actually have it when they do. So that's one thing to be careful of when using those SpO2 monitors. So next we're moving on to strokes. So the big thing with strokes is figuring out the red flags. The red flags will be your dead giveaways with the majority of these problems. So things like sudden onset, explosive or thunderclap pain, so like that intense throbbing pain that people will generally describe as the worst pain they've ever felt in their life, right? So next we'll be moving on to altered mental status. Altered mental status, though it can be, as I said earlier, a symptom of many other diseases, it's generally what's going to help determine if it's a stroke. Um, if they have an age above 50, if they have a depressed immune system like HIV/AIDS or some sort of chemotherapy, those are generally things to look out for. Neurological defects, neck stiffness or pain. So that also can be another symptom of bacterial meningitis, but I will go over that in a further portion. Fever, changes in vision, or one-sided paralysis or weakness. As we go on to the diagnosis portion, I will discuss a couple of different scales. Scales that are more commonly used would be your things like your Cincinnati stroke scale, because the vast majority of people actually do use that when determining if it is a stroke. So, we're moving on to the different types of strokes. So, a hemorrhagic stroke is a ruptured blood vessel that irritates tissues and causes ICP, resulting in severe head pain. Pain is initially localized and spreads. Symptoms include severe headaches, seizures, altered mental status. Early can be things such as headache, emesis, which is vomiting, and altered mental status. Can be caused by tumor or head trauma. This could mean this could have occurred. The trauma could have occurred, as I said earlier, hours or days ago. Ask about recent head trauma whenever you have a headache case. Just generally, it's a good scope practice because it can help determine whether or not this is a more severe issue. Also, so a more in-depth understanding of how the hemorrhagic stroke works is understanding meninges. So as I went over earlier, your meninges are 3 different layers of skin that protect and cover your brain. So when they are when ICP is introduced to them, the irritation will cause the meninges to send out, obviously, a pain signal, which can be very painful and irritating. Which is why you'll hear in a lot of the hemorrhagic stroke cases, people complaining of like severe head pain. So strokes are, so as a whole, the understanding of strokes is an interruption of blood flow to areas of the brain, resulting in loss of brain function. An environment of no O2 brain cell death can occur within minutes of no treatment for the dead brain cells. However, when there is O2 low O2 present, it can take several hours for the cells to die. When cell death or injury can occur, severe disabilities are probable. Brain cells can develop a condition called ischemia, which is a reduction in blood supply due to a lack of oxygen leading to improper function. If blood flow resumes to affected areas, it can be reversed. But the big thing with strokes as a whole is time is brain matter. With everything, it's time is tissue, and with this, it's time is brain matter, because the more time you fuck around with the patient on scene, that's more time that they have less oxygen to their brain. So the ischemic strokes will be the most common of strokes. They're about 80% of cases, and they're caused by blood clots leading to ischemia, and can happen due to a thrombus or embolus. So a thrombus would be on site. or location of the actual stroke, and that is where arthrosclerosis will eventually cause such a severe plaque buildup that it closes off the actual artery itself. The other would be the embolus, which is from a remote area. This can be things like the coronary artery due to coronary artery disease, where it floats up from the small arteries up to the really small arteries in the brain, causing, as it was stated previously, the blockage. An ischemic stroke is the most common non-hemorrhagic stroke, so that's a good way to remember it. So going back to the hemorrhagic stroke, a more in-depth analysis would be, I know I talked about it earlier, but a hemorrhagic stroke is a pretty severe one because it's the most fatal stroke, because the majority of people who do have them are most likely going to die. So the results of brain bleeding, basically, 13% of all strokes are your hemorrhagic strokes. It's when the vessel ruptures due to accumulated blood clots, when the vessel ruptures, then accumulated blood clots, which compresses brain tissue. Compression prevents oxygen-rich blood from getting into the brain, causing cell death, often fatal. Caused by untreated elevated blood pressure or very high blood pressure. It weakens blood vessels. If ruptured, it can increase ICP. Proper treatment of those elevated blood pressure patients and your very high blood pressure can prevent these pretty gnarly consequences. So another thing will be is some people are born with a weakness into their artery walls, such as an aneurysm. And an aneurysm is swelling of an artery resulting from a defect or weakness. It's generally, when they pop, it's described as the worst headache ever. It's a sudden onset and it's a severe headache. In otherwise healthy young patients, often you can see these things caused by Barry aneurysms. Barry aneurysm is generally a genetic defect in which a balloon-like structure forms into the artery, causing a aneurysm, which eventually, once dissected, can result in a hemorrhagic stroke. So, a transient ischemic attack, also known as TIA, mimics a stroke, resembles the scenes, but goes away with time. The best way to remember that is it's like an angina to a heart attack, because normally 1/3 of folks who do have a TIA are going to have, as some people will call it, the big one, the massive stroke, because it is a pretty big prerequisite. It's about 1/3 in cases will have a stroke after they've had this. So it is very important to treat this as a stroke and get them treated, because there are many different medical procedures, such as thrombose therapy, I believe it's called, where basically they can get those brain clots and those thromboses brought back down to a manageable level so that they won't have to worry about it. That's more pertaining to the non-hemorrhagic stroke route. So the big things about strokes is understanding what mimics them and what might seem like them, which are things like your subdural and epidural bleeding, as we discussed earlier. Those are bleeding between either the skull and dura, which would be your epidural, and your dura and brain, which would be your subdural. That can be caused by just general head trauma and several other things. So what we're going to go on next is the different hemispheres of the brain, because obviously your brain is split into two major hemispheres, your left and right. So the left hemisphere is going to exhibit a speech disorder called aphasia, an inability to produce or understand speech. Speech problems can vary widely. Some can speak, but they'll answer with completely nonsensical answers, and this is generally resulting in right side paralysis. The right hemisphere is actually the one that you'd be more susceptible to having issues that can cause very long-term issues, and this is because they can understand speech, but generally they can understand and speak, but generally it's slurred and hard to understand. They are generally oblivious to their problems, and they have a neglect for their body, and it can be things like they just don't notice that they had a stroke, and they're just not willing to ask for help. Things that you can help diagnose this with is vision. So they will possibly have one good eye and one bad eye. So if you're standing in their good eye, they'll make no conscious effort. But if you're standing in their bad eye, they also won't make any conscious effort. So it's understanding, well, sorry, they will. So it's paying attention to how they see you and how they perceive you. They also, due to this, will not correct themselves. So they will, when sitting down, lean over to one side, indicating that they are having a stroke. Um, so this neglect and lack of pain results actually in a delay. Um, so yeah, the big things to remember about the hemorrhagic stroke, as I've gone over previously, is that the pressure prevents blood from getting in. So the big thing about ICP is it actually isn't the blood loss that kills them. It's the ICP because it prevents any blood from getting into their skull. Because you do have to remember, the skull is constructed in the mind of protecting your brain. So, if there was a lot of room and a lot of area for people to have fluid build up, then we would be getting concussions very regularly and very big problems from that. So the big thing is obviously remembering that your brain does not have a lot of area to be taking a lot of this. So a couple other things that mimic strokes would be your hypoglycemia and your postictal state, which we will cover in the seizures portion. So seizures are a neurological episode caused by a surge of electrical activity in the brain. It can take form of convulsions and characterized by generalized, uncoordinated muscle activity, and or can be associated with a temporary alteration in consciousness. About 2 to 3 million people have epilepsy, which is a common cause of seizures. There are two groups of seizures, generalized and partial/focal. Generalized or tonic-clonic seizures, and as we went over earlier, tonic-clonic generally, I wrote it down somewhere. I forgot it off the top of my head. I'll put it down in the comments if I can't find it real quick. Tonic-clonic actually does mean right here. So a tonic-clonic seizure can actually mean, or it actually means, oh fuck. Alright, yeah, I'll just put it in the comments. I'm sorry about that. But yeah, so it's a result from abnormal electrical discharges from a large area of the brain, usually including both hemispheres, but can also include just one. This is characterized by unconsciousness and a generalized severe twitching that lasts minutes or longer. As we'll go on to next is the absence. Absence is similar, but this is just a brief lapse. These are known as obviously the absence seizures. These can be those people who will just stare at you and not know what's going on after you guys begin to talk. So next we're moving on to a partial or focal seizure. Those begin in one part of the brain. That's the big way to remember it. So the big thing about a semi-partial simple partial is a conscious patient that includes a numbness, weakness, dizziness, visual changes, unusual smells or taste, twitching of muscles, and extremities that spread slowly from one portion to the other. They may experience brief paralysis, but the big thing about this is the lack of mental change, if you will. They maintain the same. A complex partial seizure is an altered mental status patient that results from abnormal discharges from the temporal lobe of the brain. Lip smacking, eye blinking, isolated convulsions and jerking of the body, such as the arm, may experience unpleasant smells and visual hallucinations. They generally exhibit a uncontrollable fear and repetitive physical behavior. So these are the patients that will be like sitting and standing several times. As I said about absence, syncope is a patient. These will generally be seen in geriatrics where they'll stand up and then just pass out. These will not be followed by a postictal period because they are just simply a lack of circulation. These can be signs of bigger issues. So it's always good to figure out if this is what this is through medical history. Um, if they last, oh, sorry, aurora is, some patients will experience these before the seizures. These can be things like metallic smells. Everyone has a different one. It can really just matter on who they are and how they respond. But they're not guaranteed, and just because someone had an aurora previously does not mean they will have one before their next seizure. Postictal state is a period after the seizure where the body recovers. Breathing and muscle composition are altered. So this is where you'll hear that deep, rapid breathing. Generally, this will obviously be very effective breathing. This is to prevent basically any sort of acidosis in the body due to just that insane amount of exertion that happened in that 5 to 30 minutes of the seizure. Um, so yeah, seizures that last longer than your 5 to 30 or 5 minutes are known as status epilepticus. Um, so yeah, the big causes are epilepsy, which is a congenital failure, structural, which is tumor, infection, scar tissue from head injury. Metabolic will be your hypoxia, abnormal blood chemical values, hypoglycemia, overdoses on drugs, poisoning, and sudden withdrawals of drugs and or alcohol. Your febrile will be sudden spikes in fever. So a big thing to remember when dealing with seizures is if they are basically having reoccurring or prolonged seizures, this is a life threat, and you will need ALS to help make the best intervention. So additional neurological issues will be things like bacterial or viral meningitis. So I will go here to describe to you what bacterial meningitis is. An inflammation of the meninges caused by a bacterial infection, and this would be considered a central nervous system infection. Symptoms include headache, stiff neck, fever, sensitivity to light. Um, Generally, when we move on to the next section, we will discuss how to treat these. So hypoglycemia, that is in which the patient, this is seen in your diabetic patients, where they do not have enough glucose, and when they do have a seizure due to hypoglycemia, they will tend to use all their glucose up. This can lead to obviously worsening conditions. Delirium, which, as I've said earlier, or I haven't said at all, delirium is a symptom, it is not a disease. So you have to remember that when dealing with these patients, they can exhibit signs of people with severe schizophrenia, but these can be due to many different things. So you have to recognize that and see what's going on, because this delirium can come across as untangible speaking. These people can be very aggressive, and that can scare a lot of people, and obviously it's very scary for the person themselves. So you do have to remember that. So yeah, next we'll be moving on to the diagnostic and treatment. So as an EMT, the big thing you have to remember is EMTs do not diagnose, but rather they figure out a path of treatment and they follow it. So if it's a cardiac origin, you figure out what you think the cardiac origin is, and then you treat for it. Because a lot of emergency medicine is not, I wouldn't say it's not an exact science, but rather it's not a, you're not a doctor, if that makes sense. You're not someone who understands 100% of what's going on with the patient, so you can't really make the best prognosis on the patient, or sorry, diagnosis. So, next, strokes are time critical. ALS is going to be your best friend in these situations because they can turn the tides of these and allow for people to have the best chance that they have when it comes to these issues. The big thing about strokes is maintaining ABCs, because if you don't have your ABCs, then the patient is not going to be living very long. So you might see ALS put in advanced airways and give medications. That's something that as an EMT will not be able to do. With seizures, when acute, rapid transport and maintaining the ABCs is best. When you see this chronic, you're generally going to have to transport and assess the ABCs, or sure the ABCs. With seizures, generally when they're these acute issues or they're reoccurring and prolonged, you will see ALS come to scene, and that will be obviously your advanced airways and maintaining people that way. Vitals are the key to determining any one of these events because a stroke will generally be seeing things of abnormally high blood pressure. Because even though you do have a brain bleed, you will have an alarmingly high blood pressure because the body will have a compensatory mechanism to basically get the blood there because the brain's freaking out because of the lack of blood. Your environment and scene safety is key. When you see someone seizing, like a generalized seizure, and they are completely out of it, and you see like syringes of clear drug paraphernalia, you might want to use Narcan rather than per se oral glucose. It's determining what the situation is, and along with scene safety, obviously, if a patient is delirium, or they're taking drugs, you can hear. I've been told like there's like small little girls beating the shit out of grown ass men. So, it really is a pretty crazy thing. Hypoglycemia can be diagnosed with a glucometer. So generally, you're looking between 60 and I believe it's 100 for your glucose. And if it is above that, that will be your hypoglycemia, and then if it's below that, that'll be your hypoglycemia. So yeah, uh, delirium, as I said, it can be very scary for the patients. So a calming presence and keeping everyone safe is key. Um, Headaches, such as migraines, specifically if transported, is requested. Generally, a low light environment, low flow oxygen transport is the most recommended one. With a lot of people who have headaches, really you can do the placebo effect of giving them a nasal cannula with like 2 liters of oxygen or something so it doesn't irritate their noses, specifically in the cases of like sinus infections, and it can possibly even help some of their issues because with medicine, a lot of it is just helping someone because people do freak themselves out. That is probably the most important part about treatment is maintaining a calm, cool composure so that you yourself don't become a patient and you keep yourself square. Meningitis, generally want to keep them in a dark environment with no lights on, sirens, transport, um, if possible. It is generally the most optimal way of transporting them because those patients will be suffering from very severe issues that can be very difficult and frustrating. And I believe that is the end. So, tell me what you guys thought. Um, Thank you for giving me a listen. This should help you with the FISDAP. I will put in the comment section, like I did in the last one, the medical uh, Quizlet. That should help you out. Um, I would suggest if you're still in class, taking good notes, or just use your JBL or the actual book itself, because those will probably give you the best opportunity to succeed. All right. Have a good day.